We're doing a program tonight. This is an MS Views and News program called MS Views Now, which began during the COVID era. And this program tonight is supported by Sanofi. And this is an MS Views and News educational program, and let's get started here.
Howdy. Hey, everyone. Aaron Boster here. Delighted to be here with you. I want to say thank you to MS Views and News and Stuart for inviting me to come back and speak with everyone. I want to say thank you to all of you for taking some time out of your evening to up your game and learn more about how to make MS boring and how to live your best life despite having MS. Tonight, I'm going to be talking about a topic which is bluntly all too often ignored. I see patients from around the United States who come for consultative visits at the Boster Center, and repeatedly I'm struck by the lack of attention to quality of life and symptomatic management. Now, I'm not trying to talk poorly of others. I'm simply saying that it's been my observation that there's a lot of opportunities to improve someone's life by focusing on symptoms. When I'm trying to help a family make MS boring, I divide my thoughts in three. There's treating MS attacks when they occur. So when you have a new neurological deficit that you haven't had before, it sticks around for longer than a day, you're not having a fever, there's concern on the table that you're having an attack. And there are lotions and potions that we use, like IV steroids or high-dose oral steroids or things like that, to hasten recovery. And that is not the topic tonight. A second very large focus of MS care has to do with trying to slow the disease down. So this is behavioral measures and medicines like disease-modifying therapies, which are intended to prevent MS attacks from occurring, prevent new structural brain damage on the brain and spinal cord, seen on the MRI, to slow brain volume loss, and to slow disability progression. And that's a very important element to MS care, but that's also not the topic of tonight. The topic tonight is where I think we should spend about 70% of our clinic time. And that is improving quality of life. And the way that I improve quality of life is I treat symptoms that suck, to be blunt. I'm going to use an off-color example just to frame what I want to talk about. Some men with multiple sclerosis develop erectile dysfunction. Not all, but some do. If a gentleman with MS has erectile dysfunction and it bothers him, I prescribe him a little blue pill called Viagra. If a guy with MS has erectile dysfunction and he doesn't care, I don't care. Because treating, in this off-color example, erectile dysfunction doesn't slow down or speed up MS. It just makes Friday a really different evening. And so for that individual, we can improve his quality of life in this example by improving something which is important and really relates to his quality of life and symptoms. And so tonight, I'm going to be tackling that third bucket, symptom management. Now, what is a symptom? A symptom is something that stinks. And when you have MS, you can develop an attack where you lose a function. Let's say that you develop a loss of sensation in your leg, and there's actually a burning sensation in your leg from an MS attack, and then it recovers 50%. And so you're left with a numb kind of burning feeling in your leg, which is chronic. And now you've developed a new chronic symptom. Also, independent from attack, patients can accrue neurological symptoms, which can really erode their quality of life. And so tonight, that's what I want to be discussing with you. I'm going to share with you sort of the symptoms that are always top of mind when I'm meeting with a family. And I'm going to frame it talking about the most important invisible symptoms that I see. And then when we open up questions, if you have questions particularly about symptom management, I'll be really excited to answer them. So many people will appropriately refer to MS as an invisible disease. And any of you that have followed my YouTube channel know that I'll sometimes say things like, well, honey, you look so good. Because you do. You have two eyes, two ears, you have a nose, you have a mouth, your arms move, your legs are moving. And people can't see the vast majority of MS pathology in you, which doesn't make it not real. It is real. It doesn't make it awful because it is awful. And it's really frustrating. So I want to spend some time with you guys tonight talking about what I refer to as invisible symptoms. And with almost every clinic visit, I ask someone how they're doing with the up theirs. You know, the up theirs: energy, mood, thinking, and memory. Energy, mood, thinking, and memory are three symptoms that I sort of think of as the up there's. They're in the head that are all tied together with a bow. And fatigue or energy is the most common symptom in MS. Pathologic fatigue is the #1 reason why people leave the workforce in the setting of multiple sclerosis. And it's invisible. And it's really, really frustrating. This is not, I didn't get a good sleep last night. This is, I can't sleep enough and have enough energy to function. Oftentimes, patients will describe to me they're desperately trying to stay awake. They're trying everything they can do just to be able to attend, and they're exhausted. The best example that I've come up with trying to help a spouse understand what it might feel like is if you went to work on Monday, like a normal Monday, came home and had dinner with your family, cleaned up dinner, and then didn't go to bed. I would recommend that you start watching my YouTube videos. Stay up all night, get less than an hour of sleep. Jump in the shower Tuesday morning, go to work Tuesday, work a full day on Tuesday. Tuesday night, eat dinner with your family, and then I want you to stay up all Tuesday night and watch the rest of my YouTube videos. Now, Wednesday morning after breakfast, we're going to go for a walk and talk about fatigue. And oftentimes, that's what my patient will describe when we discuss pathologic fatigue. Except to look at you, honey, you look so good. In fact, in our culture, if you say, I'm tired, the person listening says, yeah, me too. It's almost like, hi, how are you? Good, how are you? I'm tired. Yeah, me too. And that can be really, really frustrating because pathologic fatigue erodes the quality of your life. One of the ways that I think it's helpful to think about fatigue in MS is something called spoon theory. So some of you listening right now may have heard of spoon theory. For some of you, maybe this is the first time. And if that's the case, I'm excited that I get to share it with you. I did not invent spoon theory. In fact, it was a concept invented by a woman who has a different chronic autoimmune disease called lupus. And it works really, really well in the setting of multiple sclerosis, helping friends and family understand what you mean when you say you're so darn tired. So I wish that I had brought up a spoon from my kitchen when we were talking, but pretend I have a spoon in my hand, okay? A spoon in this is a unit of energy. So you wake up in the morning with all the spoons you're going to have. So let's say I wake up in the morning, I have 50 spoons for my day. And I take a shower, and so that's a spoon. I'm going to spend about an hour in my electronic medical record prepping my charts and answering questions. So maybe that takes me 4 or 5 spoons. I'm going to get my kid up and get them ready to go to school. That's going to take maybe 2 spoons because they don't want to wake up. Drive my kid to school. That's a spoon. Get myself to work, get myself oriented, and that's maybe another spoon. So I've spent several spoons getting ready to start my day. And as I go through my day, I'm expending spoons. I'm expending units of energy. In the setting of MS, you wake up in the morning and you wake up with 10 spoons. You don't have 50 spoons, you only have 10. And for you to accomplish the same tasks takes more spoons. For you to get your kid up and go to school might not take 2 spoons, it might take 3. And you may find that you've literally used up all your spoons by noon. So you're not even halfway through your workday and you don't have any spoons left. You're all out of energy. You're literally running on fumes. And what you do is you start to tap into tomorrow's spoons. And I have found over the years, talking with families in my clinic about multiple sclerosis, that sometimes that's a helpful tool to help them understand what we're talking about with fatigue. When we talk about the up there's, the invisible symptoms of thinking, memory, energy, and mood, let's now talk about thinking and memory. Because when you have multiple sclerosis, a good percentage of patients, more than 50% of patients, will experience some difficulties with thinking and memory. Now, most Americans, when they hear about thinking and memory problems, they automatically think about a different disease, Alzheimer's dementia. And MS Cog-Fog is nothing like Alzheimer's dementia. In MS Cog-Fog, you're not going to forget who your loved one is or where you are. That's not what happens. What happens in the setting of MS Cog-Fog is it's harder to multitask. It's harder to work under time pressure. It's harder to remember lists of things in your head. It's harder to work on the spot. This is called executive functioning and attention. It's hard to lock on to a task. Now, when I say attend, I'm not talking about like you're just not paying attention. I mean, you are desperately trying to take in what they're saying. And you're looking at them and you're not doing anything else. And you're really, really trying and you can't absorb the information. You can't attend to it. And if you can't attend to something, you can't remember it. And cog fog is insidious, and it's closely related to fatigue. Many of my patients do their best thinking, their best working, their best writing, their best communicating first thing in the morning, the first half of their day. And they may find as the day goes on that they have more and more trouble with cognition. And this can be a major impediment. It can be very, very frustrating. It can tax relationships. It can tax work. I've had many patients who in previous years were employee of the month, outperforming all the other telemarketers. And then, they may end up ultimately losing their job because they can't keep up because of cog fog. The third factor when thinking about the up there's is mood. And people impacted by MS are twice as likely to experience depression compared to the general population. That's a really, really large number. People impacted by MS are twice as likely to experience anxiety compared to the general population. They're actually at a much higher risk of having bipolar disorder compared to the general population. And I want to focus on depression and anxiety because those are so common. And the problem with depression and anxiety is they color everything gray and ugly. And it really saps your quality of life and your desire. It saps your motivation. And as you can imagine, it's closely tied into fatigue, into cog fog. So when I'm talking to someone in clinic, I say, hey, how you doing? They say, oh, I'm doing pretty good. I say, really? Well, how are the up there's? What's going on with energy? What's going on with mood? And what's going on with thinking and memory? And I want to share with you that there are a host of things that we can do to improve the up there's. But first, a quick sip of water. So what are some things that we can do to work on the up there's? Now, there are a lot of behavioral measures that we can do to improve the up there's. We could have an entire discussion on how to improve sleep. Because if you sleep better, you think better, you have more energy, and your mood improves. That's a fact. We could have a very large discussion about nutrition and increasing hydration and avoiding ultra-processed foods and avoiding sugar-laden foods and fast foods. And that actually can have a major impact on energy levels and mood and on thinking and memory. But I want to focus on two things that I want you to be thinking about. Number one is exercising as part of your lifestyle. And you may say, what? I thought we were talking about thinking and memory. We are. It turns out that people impacted by MS who exercise as part of their lifestyle improve cognitive function. You heard me right. You literally improve cognitive function. You markedly improve energy levels. And it's been shown time and time again to improve mood. So exercising as part of your lifestyle is a critical aspect of MS care, not just because it slows the disease down, which, by the way, it does, but also because it can treat some of the worst invisible symptoms, such as the up there's. The second thing I want to talk about are medicines. Now, I'm an allopathic doctor. I'm an MD, all right? So part of my training and trade is prescribing medications. And doctors are good at passing out medicines. We're not always good at removing medicines. And the reason I bring that up is one of the ways that we can improve cognition, improve fatigue, is by removing medicines that we don't need to be on or cutting medicines in half. Many times I'll see a patient in consultation and they'll be on 7, 8, 9, 10, 15 medicines. They're on a tremendous amount of medicines. They're on way too many medicines. And the interactions of those medicines compounded can contribute to cog fog and can contribute to fatigue. Many medicines that we use with excellent intentions, for example, narcotic pain medications can be given by a well-intended doctor, and it can destroy your energy levels. For example, there are some old school bladder medicines which are anticholinergic in their mechanism, and they can help with the bladder, but they can really tank thinking and memory. For example, many patients have spasms, and the medicines that I use to treat spasticity can impair fatigue or make fatigue worse and can impair thinking and memory. And so one of the ways that we can improve the up there's is literally by removing unnecessary medicines. So one of my challenges to you tonight is the next time you see your provider, say, hey, listen, can we go through my med list and try to reduce any medicines that we can cut back on? And are there any medicines here that I don't need anymore? And I would also challenge you that every time your provider says, let's prescribe a new medicine, say, okay, doc, which one are you going to remove? All right, because I don't want to go up in the number. If you're going to add one, let's take one away. My last comment about the up there's is there are medicines which trick the brain into being more awake, which can be life-changing medications. A couple examples that I use in clinic a lot is a medicine called modafinil, or there's a new version called R-modafinil. So the trade names are Provigil and Nuvigil. And these are central acting stimulants. They're medications which they sometimes give airline pilots when they fly across the Atlantic to keep them sharp and awake so they can do a good job flying your airplane. We can also use other medicines like the amphetamine salts, things like Adderall and Ritalin, Vyvanse, these kind of medications. And these medications help people attend. They help you focus. By attending, it helps you take in information, and it can improve cognitive performance, and it can massively help with energy. Now, treating depression is a whole separate topic, but fortunately, depression is oftentimes very easily addressable. And as it relates to allopathic medications, there are a host of really outstanding antidepressants, things that you've heard of like Zoloft and Paxil, things like Lexapro, things like Cymbalta. There's a host of them, and they can be life-changing. So I want you to ask yourself the question, how am I doing with the up there's? Energy, mood, thinking, and memory. And if you're not living your best life, even if you're not having attacks, even if you're not having new spots, if you're not living your best life because there's issues with fatigue, with cog fog, and with depression, I want you to bring that to the attention of your provider. Now, I'm going to shift gears from the up there's to the down there's. You know the down there's, bowel, bladder, and bedroom. Now let's talk about the down there's. If you would like to make an adult human miserable, if you'd like to make someone have a really, really bad day, mess with the down there's. All too often, people impacted by MS can have difficulties with bladder function, they can have difficulties with bowel function, and they can have difficulties in the bedroom. And these are sensitive topics. It's not the kind of thing that you want to bring up in a group of mixed couples, like, hey, I have trouble getting an erection, or hey, I wet my pants, or I haven't pooped in over a week. And yet, this is the reality of a lot of families impacted by MS. And it's embarrassing, and it's sometimes very, very painful, and it can destroy relationships, and it can make you pull away and fail the litmus test of life. And so I don't want that for you. So now that we've talked about the up there's, let's focus a little bit talking about the down there's. We'll start by talking about bladder. There's 3 common problems that people can have with bladder in the setting of MS. The most common, I would submit, is overactive bladder. And this is when the bladder is a tight little spastic racquetball. So it's like a little tiny racquetball that can hold, maybe a fourth of this bottle of water. And to add insult to injury, because of damage to the spinal cord, as your little tiny racquetball bladder is filling, it's not informing your brain that it's near full. And so you get the memo when it's way too late, and that thing is full to the brim, and you barely have any time to get to the bathroom. And what happens clinically is something called urgency. Oh my God, I gotta pee right now. And sometimes you can't get your pants down fast enough and you start going. Or frequency, that you go and now you gotta go again. And then you gotta go again. And you're getting up way too often to go to the bathroom. Or nocturia, where you're waking up multiple times a night to go to the bathroom. And sometimes, as I alluded to, you can't get there in time, and you'll literally have a potty accident because you can't get there fast enough, and you'll wet yourself. Another problem, which is sort of different from that, is called urinary retention. This is not a problem with the actual physical bladder, the bag that holds the urine. This is a problem with the outflow tract, which is called the urethra. So the urethra goes out to the toilet. That's what you pee out of. And sometimes in the setting of MS, the urethra will tighten down and spasm, kind of like taking a McDonald's straw and tightening it down to the size of a swizzle straw. Now you're trying to push urine through a swizzle straw and it won't go. And this has a host of different kind of symptoms in the setting of MS. So instead of overactive bladder, where you run into the bathroom and you can't get there in time, you go all the time, it can be really hard to start your stream. And it can be embarrassing. You sit there and sit there and push, and sit there and push, and then sometimes barely anything comes out. You just have like a little trickle. And what can happen in the setting of urinary retention is double voiding, where you think you're done peeing and you step out of the bathroom, oh my God, you got to go back, you're not done yet. You can have leakage, where it's kind of dribbling. And sometimes the amount of urine in the bladder and the pressure in the bladder builds up, and it finally overcomes the outflow tract. And then you'll literally have a complete emptying of the bladder, and you'll just completely wet yourself in a surprising fashion. You didn't even know it was going to happen. Now, I said there's three kind of bladder problems because sometimes nature's too generous, and you can have something which is called dyssynergy, where you have both a tight little racquetball bladder and a closed bladder neck, and you can have both. And so those patients will have urgency, they'll have frequency, they'll have nocturia, and they can't empty all the way. Now, there's a host of things which can be done to improve MS bladder, and they all start by you coming forward and saying, hey, my bladder's not working, doc. I'm really having some trouble with my bladder. And we could talk for a very long time about various things that we can do, but I'm only going to talk about three in the interest of time. The most powerful tool, which is underutilized, is a pelvic floor physical therapist. So there are physical therapists that are dedicated to rehabbing a busted knee, like orthopedic physical therapists. And there are physical therapists that have extra training in neurology. And so they can help you with unsteadiness of gait, walking like you're drunk. They can help you with spasticity. They can help you with weakness. They can help you with vertigo, like feeling like you're spinning. And there's a special group of physical therapists called pelvic floor physical therapists. And they are wizards and warlocks at retraining your bladder pelvic floor to help improve bowel, bladder, and sexual function. And they're absolutely amazing. I am always amazed at how much people improve when they see a pelvic floor physical therapist. And I will never, ever forget the very first patient that I sent as a doc to see a pelvic floor PT. And this nice young lady had really bad MS, and all the MS kind of settled in her groin. She had a lot of bowel, bladder problems, a lot of sexual problems. We sent her to a pelvic floor physical therapy, and she sent me a text message. And of course, this is like, I don't know, almost 20 years ago, but I kept the text message for as long as I could. And it finally fell off. But it said something to the effect of, hey, Dr. B, thank you for sending me to Karina. That's the name of the pelvic floor physical therapist. Sex is no longer painful. But more importantly, I'm now convinced that I can crush beer cans with my lady parts, which I just thought was freaking awesome. So a second thing that you can do to help with bladder problems is counterintuitive. A lot of patients, when they're worried about having an accident, they don't drink fluids. They just say, okay, well, I'm going to go out today. I'm not going to drink any fluids because if I drink fluids, then I may pee. And whereas I understand that rationale, that's actually not the way things work. You will make urine as long as you have blood, right? The kidneys filter blood to make urine. And so if you are dehydrated, you're still going to make urine, but you will make super, super concentrated urine. And sorry, I just realized that my computer's not plugged in. And so if I don't fix that, we're going to have a little problem. Give me a second, guys. Okay, I apologize. But I was worried it was going to keel over. So thank you for helping me with the technical difficulties. So when you have MS and you're having bladder problems, the thing to do is actually counterintuitive. You need to drink more water. Why? When you drink more water, the bladder is the urine is diluted. So instead of ultra concentrated urine, you have dilute urine. Concentrated urine irritates the bladder wall, right? It causes the bladder to spasm and makes the urgency worse. Diluted urine is less concentrated, there's less toxins in it, and it will make the bladder less spastic. It'll also help stretch the bladder. And the other thing about not drinking a lot of fluids and having concentrated urine is that's a great environment for bacteria to live in. So if you had a cup of urine and you left it there for a while, it's going to get pretty stinky with bacteria. And the same thing can happen in your bladder. But if you're drinking a lot of water, you're constantly flushing your bladder and you're flushing out all this bacteria. And so that can be extremely valuable. And so as weird as it may sound, if you want to try to control your bladder better, you got to up your water game. And I'm going to couple that with a tool which a urologist taught me that I think is brilliant. And that's to do what's called timed voids. See, in the setting of MS, because of brain and spinal cord damage, as your bladder is filling, you're not always made aware of it. You're not informed. And so you might not realize that your bladder is half full or 3/4 full or all the way full. So what I recommend doing, in addition to upping your water game, is I recommend that at the top of every hour, you excuse yourself and go to the John. Try to pee. Now, sometimes you may go and not need to, but I bet you that sometimes you'll be surprised and you'll actually say, oh my goodness gracious, I didn't even realize that my bladder was full, and and then you can empty. If you can keep your bladder empty, you're not going to have these oh no moments. And so those are 3 things that we can do: pelvic floor physical therapy, upping your water game, and timing your voids to help with bladder problems. Again, we're talking about the down theres. The second thing that I want to talk about as it relates to down theres is bowel function. And it's not discussed enough, but many people with MS are profoundly constipated, and they have slow gut transit. So the stool and the food which is being digested moves through the colon a lot slower, and it can cause some very serious problems. Now, not everyone with MS has constipation, and there are some people that have sort of IBS where they'll have some diarrhea, but very often we have constipation. And so there are a host of things that we can do. Most of them are nutritional to help with constipation. I will throw out 3 things that can help with constipation. Number 1 is to exercise. The more you move around, the better you'll move your bowels. Number 2 is to take advantage of something called the gastrocolic reflex. So gastrocolic reflex. In the morning, when you wake up and you have your first hot beverage, whether that be cocoa or tea or coffee, and that hot beverage hits your stomach, it triggers the gastrocolic reflex. And about 15 to 20 minutes later, your bowels try to empty. Now, in the setting of MS, you might not be made aware of that. You might not know that it's trying to empty, but it's true. And so you can remember that. And the best time for you to have a meaningful bowel movement is about 20 minutes after your morning breakfast or your morning coffee. So go sit on the John and try to poop. The second best time is after lunch. The third best time is after dinner. And I'm going to kick that up a notch, and I'm going to teach you something called digital rectal stimulation. Now, before you go, ew, now look, you're an adult, you're needing to poop, you're in the bathroom by yourself, and you can wash your hands. So I don't want to hear, ooh. And you insert the finger into the rectum, and you move it in a circle. There's a million nerve endings in the rectum. They go straight up to the spinal cord, and they send the spinal cord a message. Time to poop. And that can help your spinal cord figure out what it's supposed to do. So coupling the gastrocolic reflex with digital rectal stimulation is a great way to try to move your bowels. Now, there's a host of other things that we can talk about as it relates to the down theres. And I really didn't do the third one, bowel bladder bedroom, justice. But in the interest of opening up the discussion to the 102 people that are live online with us tonight, I'm going to turn the microphone back over to Stuart so that we can start to do a Q&A. And again, as always, thank you for learning about MS with me. And if you're having problems with the up theres, or if you're having problems with the down theres, get ye to your neurologist so that we can help make it better. Stuart?
Get ye. Thank you so much. Everybody give him a round of applause. I can't hear you, but give him a round of applause anyway. Just pretend like I can hear you and that Dr. Boster can hear you. Thank you so much, Dr. B. All right. We've got a lot of people that have asked questions. We've got a lot of your howdies that are out there as well. So I'm not going to call them all out individually, but they are there. So let me just get into the questions. There are several people though that have asked more than one question. Just know that I might get to them all, but I'm going to jump around and get in other people's questions as well. So let's start off with what do you recommend for heat intolerance? Since we're now jumping into the season of heat for most of us here in the United States, now would be a good time to discuss this.
Absolutely right. So there's several things that you can do. Heat intolerance is something which is somewhat unique to multiple sclerosis, where it doesn't mean I dislike heat. It means when my body gets overheated, whether it be because I'm in southern Florida and it's 110 degrees outside, or because I'm exercising and I'm raising my core body temperature, your neurological symptoms can get worse. You literally are heating up your body and you're short-circuiting your spinal cord and brain, and your baseline symptoms can intensify. And so, for example, it's not uncommon, I'll hear a story about someone who is going on a hike in the summer, and partway through they start to drag their leg. And the longer they keep walking, the hotter they get, the more and more they drag their leg until they literally have to stop. Excuse me. So what can you do to help with heat sensitivity? There's a couple things that you can do. Number one, you can play smarter, not harder. What do I mean by that? Well, let's use the example of hiking. Plan your outside activities first thing in the morning before the full sun comes up, or do it late at night after the sun has set. Don't plan on going for a walk in Appalachia Trail at noon because it's freaking hot outside. Use the morning or the evening to try to help you. Another tool is there's actually a medicine. This is a prescription medicine, so you got to get a prescription from your neurologist. And the medicine is called 4-aminopyridine or delfampridine, or the trade name is Ampira. Over in Europe, it's Fampira. And this is a pill. It doesn't slow down MS, but it treats the symptom of heat sensitivity. It's a pill you take twice a day, once in the morning, once in the evening. And only about a third, maybe upwards of half of patients respond. Now, I have found over the years that it can take 6 to 8 weeks to figure out if it's working. But if it's working, boy howdy, it's remarkable because you'll go out in the heat and you won't melt. And it can help with heat sensitivity. Now, all pills come with side effects, and so you have to make sure that medication is safe for you. But if you have heat sensitivity, definitely talk to your doctor about trying Ampira.
Thank you very much. All right. Is MS the reason why a person could have trouble during intercourse when that person is a woman and is 63 years old and in a wheelchair?
So as part of the down there's, that includes bowel, bladder, and bedroom. And very, very commonly, men and women with MS can develop difficulties in the bedroom. That can come in many different flavors, and there's typically 3 that I see. One is low libido, or a decrease in interest. And there's a lot of different reasons why that can happen, but that's actually pretty darn common. The second one is decreased sexual sensation or pain instead of sexual sensation. So touching the down there's, it's either numb or it can actually physically hurt. That's a term called dyspareunia. Men and women can have difficulties with mounting a sexual response, meaning gentlemen can develop difficulties with obtaining and maintaining an erection. Women can have difficulties in obtaining lubrication. And lastly, you can have something called difficulty with orgasm or anorgasmia, meaning it's nearly impossible to climax. And the good news is that there's treatment for every single one of the things I just mentioned. It's very, very sad to me when someone is suffering from sexual dysfunction and they're not comfortable sharing, because there's all kinds of ways to treat that. And so you're not alone. In fact, the majority of people that I take care of will have some form of sexual dysfunction. And oftentimes we can figure out ways to overcome that. Let me teach you 2 quick tricks to improve the bedroom. Number 1, with clothes on, I want you to have an adult conversation with your lover. Right? If you're able to get naked with someone, you're able to have a conversation with that person with clothes on. And I want you to be very open and honest about things that do not work, things that you would like to try, things which are hard for you, and the goals of the evening. So many couples who have been intimate for years and years have sex without discussion, and they do it exactly the same way every time. We wait till the kids go to bed, we do kissy-kissy, we do this, we do that, we lay in this position, boom, boom, then we watch TV. And it's in the exact same fashion every time without any discussion. And so sometimes you fall into this pattern and you assume that the goal of intercourse is orgasm. It doesn't have to be. So I want you to be very honest and say, look, the likelihood that I'm going to be able to orgasm tonight is near none, but I would like to be intimate with you. I want to be able to touch you. I want to be able to love you. And that's not a goal of mine to have an orgasm. I also want you to be able to say, look, when you do X, Y, and Z, that actually, I can't feel it. I appreciate you trying real hard. Good job. I can't feel that, so that doesn't help me. And I know that you like it when we're in a certain position, but that makes my legs spasm. So if you can have a conversation a priori with clothes on about what works and what doesn't work, it's going to be such a better experience for both parties, or if you're lucky, all 3 of you, when you actually enter into the bedroom. The second thing that I'll share with you is something that I call overdrive stimulation, and this is a big one. Now, I am not sponsored by Hitachi Magic Wand, but I would love to be sponsored by Hitachi Magic Wand. That is a plug-in-the-wall vibrator, and it's this. I own one. I think they're amazing. It's like this large wand. It's wired, and you plug it in, and it's very, very powerful. And if you apply a water-based lubricant, which increases skin sensitivity, and then you apply that bad boy to the down theres, this works for both men and women, you can provide overdrive stimulation. And sometimes the degree of stimulation is enough to get the message up the spinal cord to the brain so the brain knows what's going on. So that's actually extremely common and something that we should tackle and make better.
Thank you very much. You know, a lot of people bring up that, you just mentioned it as well. They've spoken with many sex therapists along the way, and people always bring up toys. But toys don't work for a person, male or female, if they don't have the sensitivity to feel it. If they can't feel their partner, how are they going to feel a toy? All right. And so sometimes imagining, you know, maybe a story in your head, I've been told, you know, is or having your partner describe something to you that they know that you can get off with, so to speak.
Yeah, absolutely.
What's that? Yeah,
absolutely. It's the sexiest organ we have is this one up here. Absolutely.
That's right. That's what I was getting to. So so that's all I'm trying to say as well. So all right, next subject, because I don't want to get all into sex here. All right, so going back to the heat, a person asked me this morning. We have a new chat board. All right, so it's called Community Chat. All right, and people are very active in there and very engaging. And so one of the questions that came up today when talking about heat intolerance is they were talking about Uthoff syndrome, but what about a person that's sensitive to cold, and is that called anything? And I said, what's the difference? You have heat sensitivity, you have cold sensitivity. What more do you really have to say to somebody? You have to put a label on it. But is there a label for cold sensitivity?
So the answer is no. There's no special name for issues with cold sensitivity. Uthoff is a dead white man who named something after himself. So the dead white European guy who noticed many hundreds of years ago that if someone with MS got overheated, they would lose vision in the eye they used to have optic neuritis in. And there's a host of heat sensitive symptoms that one can see. I practice in the great state of Ohio, where it gets freaking cold in the winter. I've been graced with Stuart and his team will come up and visit me sometimes in December, and they'll attest that it gets pretty freaking cold here. And in the cold, there's a different set of symptoms. So oftentimes what we see in the Ohio cold is patients will have worsening spasticity. So their muscle tightness gets worse, their cramps and their spasms get worse, their stiff legs get stiffer. And so you can be kind of floppy in the summer and you can be stiff in the winter, but there isn't a special term for that.
Okay, thank you for that. All right, next, a person asks that for those that are using modafinil and still get fatigued, what would you recommend?
So there's several things that we can do. The biggest problem that I see with modafinil is that people take it every single day without a break. Now, I'm going to make my typical medical disclaimer. I am not giving you medical advice right now. I'm giving you education. I am not telling you to change how you take your medicine. I am suggesting that you talk to your neurologist about what I'm about to say. So please don't leave the chat and say, Dr. B told me I'm supposed to do blah, blah, blah. But here's the deal. If you take a stimulant every single day without a break, it'll start to wear off. Even though they're not really supposed to, this absolutely can happen. And so I ask all of my patients to have a weekly drug holiday once or twice a week. So they may take their modafinil no more than 5 times a week. They got to take 1 or 2 days off. And what those days off do is they reset the success of the medicine. And so sometimes people will take a lazy Saturday off, they'll take a lazy Wednesday off, what have you. When they go back to it, it works much, much better. And if you're not taking days off and it started to wear off, sometimes we have to do a big reset where we'll take 1 to 2 weeks off the medicine completely. And when you come back to it, boy, does it work a lot better. And so that's one thing that you can do. A second thing that you can do with the supervision of your neurologist is you can increase the dose. So the maximum dose of Provigil that I'm comfortable using is 200 milligrams twice a day, which is a lot of medicine. Most of my patients respond to 50 milligrams once a day. But my point is, working with your neurologist, you might find that you need to go up a little bit in the dosing so you can get more bang for your buck. Again, these are not things that I want you to experiment on with your own. There's risks and side effects with all the things that I'm mentioning, but with your neurologist as a partner, you can sometimes make those drugs work a little bit better.
Great, thank you. Next, is there a better option for MS spasticity than Flexeril?
Absolutely. I don't like Flexeril as an MS spasticity medicine. Personally, I have not found Flexeril to be the best medicine for spasticity. Now, there's probably MS doctors out there that have some success with it, and God bless them. And there's probably some patients out there that find some benefit, and that's wonderful. I'm simply sharing that in my 2 decades of practice, I have not had a lot of success using Flexeril. My fave antispasmodic is baclofen. Baclofen is a chemical compound which mimics GABA, that's the stop neurotransmitter, and that's the drug that I probably have the most success with. My second favorite is tizanidine or Xanaflex. Now, both medicines can cause sedation, but Xanaflex causes a lot of sedation. And so it's extremely rare that my patient can tolerate Xanaflex, tizanidine, except for before bed. And I think that tizanidine Xanaflex is particularly good at spasms and cramps. So taking 4 milligrams before bed can kind of help you fall asleep, and it can also help decrease spasms and cramps. So the quick answer is absolutely yes.
Great, thank you for that. All right, next we have, has there been any studies to show if our food or drink could contribute to MS or its progression?
That's a great topic and one that I'm very passionate about. I have several YouTube videos on my channel where I talk about the impact of different types of food and dieting and its impact on MS. The short answer is that diet has a role in MS. And in particular, diet can help manage a lot of symptoms. So being obese, particularly being morbidly obese, does speed up your disease process, and that's been proven. So people who are morbidly obese actually have more cognitive deficits, and they get worse faster compared to people who are of ideal weight. That's not a value judgment, that's just scientific facts. And when a patient takes me up on my challenges to clean up their diet, to eat foods that have single ingredients, foods that rot, foods that have to be refrigerated because they'll go bad, and they avoid ultra-processed foods, sugar-laden foods, fast foods, fried foods, diet foods, time and time again, they're blown away by what they find. What they find is they have more energy, they think more clearly, they move better, they fall less often, their bladder's under better control. And if you're listening right now saying, nuh-uh, well, yeah, try it, I dare you. In fact, I double dog dare you. And I don't think it's realistic to go from eating McDonald's cheeseburgers and guzzling down soda to having a perfectly clean diet. What I would recommend is pick one ultra-processed food a day and replace it with a healthy single ingredient food. That's a great place to start.
Great, thank you for that. All right, next one. Person wants to know if modafinil is not working for them and they've been on it for a number of weeks, then is there something else that can be tried?
Absolutely. So modafinil, which is Provigil, which is the medicine we were talking about earlier for energy, is one of many medicines. So there's another one called R-modafinil or Nuvigil, which is like the new version of that. And sometimes patients that don't respond to modafinil respond to R-modafinil. Sometimes that doesn't work, and we need to leave that topic, and we need to look at other medicines, as I mentioned, like Adderall or Ritalin, the amphetamine salts. If the person has sleep apnea, there are some special medicines which are only FDA approved for sedation from sleep apnea that can be really helpful as well.
Okay, thank you. Next, it's hard to read some of these. How much can pelvic floor exercises help men?
A lot, like a lot. They can help with bladder control. They can help with bowel control. They can help with sexual function. So it's a very, very useful tool.
Okay, thanks. Next, what do you think of cryptotherapy for helping with MS?
So I think you said hippotherapy. So
no, crypto, ice.
Cryotherapy? Spell it.
Yeah, cryotherapy. Well, they spelled it wrong. That's why I came
Right,
out.
so cryotherapy. So cryotherapy is not something I know very much about. So I can't really answer that, not because I don't want to, but because I don't know very much about cryotherapy. I don't prescribe cryotherapy in my practice. I thought that you had said hippotherapy, which I do prescribe in my practice. So I'm going to talk about that. Hippotherapy has nothing to do with a hippopotamus. Hippotherapy is the doctor word for horseback riding. And horseback riding is a really great tool for helping with a lot of symptoms in MS. If you've ever ridden a horse for the first time, you discover muscles you didn't know you had. And staying on top of a horse and not falling off involves activating the central nervous system in new ways and helps with balance and motor control and sensory feedback in a really cool way. And so one of the many ways that we can improve a lot of truncal stability and several other things in MS is through hippotherapy, which is not riding a hippopotamus.
Correct. It would be tough. All right. Next one is oxygen therapy. I don't remember what it's called, but they wrote it as oxygen therapy.
Hyperbaric.
There you go.
So again, this is not something that I routinely prescribe in my practice, and so I don't know very much about it. I don't want to speak out of school about stuff I don't know. I do know that there are some really premier MS centers in England, like at Bart's, where they do recommend that people do hyperbaric oxygen chambers. It's not something that I know enough about, so I won't speak on it.
Sure. Next, is it possible to completely cure ataxia, bilateral foot drop, and spastic legs using only physical therapy, or do these types of things require something more?
The real honest answer is it depends. Ataxia is a doctor word for walking like you're drunk, but you're not, right? And so that's unsteady gait, like if you're on a boat and you don't have your sea legs about you. Spasticity is where your legs don't bend and they have spasms and cramps. And a foot drop, if this is my leg, was where your foot falls and the turf monster can catch the ground. And all three of those are amicable to improvements through neurophysical therapy. And I said neurophysical therapy because, in my strong opinion, you're going to get better results when using a neurophysical therapist. Now, the question was, can you cure it all? And I don't know. I said it depends. If it's a brand new attack and it's early on and there's a lot of inflammation, we might see a very, very meaningful recovery. Those are symptoms which are sometimes hard to treat, and they sometimes require multiple modalities. For example, we might need to do neuro-PT to retrain gait. We might need to do ankle foot orthoses to pull the foot up. We might need to do Botox to the legs. And, we might need to use bilateral canes to help with the unsteadiness of walking.
Okay, thank you. Is walking ability worse in Black people with MS?
No, I don't think so. I don't think that there's any specifics about walking related to ethnicity. There is strong data that certain ethnic minorities can have a faster progression of disability. So it is true when you look at a group of Caucasians and a group of African Americans or a group of Hispanic Americans or a group of Asian Americans, the ethnic minorities may tend to have a faster progression of disability just overall. But I don't think that you can say that walking specifically is worse.
Okay, thank you. What do you recommend for tingling in the hands and the feet?
So this is really interesting and not in a good way. We neurologists are decent at decreasing or dampening neuropathic pain, like a painful sensation in the hand. We're not as good, honestly, about decreasing paresthesias, which is a doctor word for numbness and tingling. We can use the same medicines, the gabapentins, the Lyricas, the Topamaxes, all of these medicines, and sometimes that can help, but it's actually a harder thing to treat.
Okay, thank you. Next, what can you tell us about overactive bowel? So
neurogenic bowel is really, really frustrating. And again, if you want to make an adult miserable, have them poop their pants. It's really horrible. And sometimes in the setting of MS, you can have what's called fecal urgency. When you suddenly need to poop and you're going to go in a couple seconds, whether you get there or not. And one of the best things that I can recommend is to schedule bowel movements. So earlier I talked about using the gastrocolic reflex, and I talked about digital rectal stimulation. You can kick that up a notch. You can use suppository. You can use an enema, right? You can try to induce a bowel movement. There are medicines that you can take, promodal agents like magnesium citrate, which we in the hospital used to call a mag bomb, or lactulose, or you could use like Go Lightly, which doesn't make you go lightly. You can use a host of medicines, some of them are over the counter, to soften the stool and to help gut motility so that you can poop. And if you can have a meaningful bowel movement in the morning, you're impervious. You can go out about your day in the community with less fear that you're going to have a bowel movement when you don't want to.
Thank you. Next, restless leg syndrome. Has this anything to do directly with multiple sclerosis, or is it just that anybody can have this?
So restless leg syndrome is a kind of a form of neurological torture. It's a phenomenon which does not create a problem when we're out and about moving around. It only becomes a problem when our legs are at rest. So you oftentimes hear about it when someone finally at the end of the day climbs in bed, when they're laying in bed and their legs are finally still. But it can also happen to that same person when they're sitting on the couch because their legs are at rest. And what happens is they develop a compulsion, a growing, building need to move their legs. And it builds up and it builds up and it builds up and they can't ignore it. And they finally voluntarily shake their legs out, or they'll jump out of bed and walk around a little bit and it'll go away temporarily until they're still again. And this is a form of torture, and it can keep someone from being able to fall asleep. It's very, very frustrating. Now, the most common cause I would submit to you is actually iron deficiency. And so when one of my patients has restless leg syndrome, one of the first things I check is an iron and a ferritin level. There's a couple labs that we check. And if we identify that they're low iron, we can sometimes supplement iron and we can make the restless leg better. But restless leg syndrome occurs more often in people impacted by MS because of spinal cord damage. And so I find restless leg to occur very, very often. I want to highlight the difference between restless leg syndrome and spasticity. Both increase their frequency when you're in bed for different reasons. If you're laying in bed and completely under no control of your own, you kick your partner, that's a spasm, right? That's spasticity. If you're laying in bed and your calf cramps up, that's spasticity. The restless leg is different. Yes, the legs move, but you're voluntarily moving them because of the compulsion to do so. Now, the good news is there's a lot of medicines to treat restless leg syndrome. In fact, some of the very best medicines like Requip and Mirapex that we use were invented originally to treat Parkinson's disease, and they're exquisite medicines to treat restless leg. And so we use them routinely in our clinic to make restless leg a thing of the past.
Thank you. I'm going to ask that nobody else send in any more questions because we have so many right now. I don't know how we will finish them all over the next 20 minutes because Dr. B has a strict regimen that by 8:15 p.m. Eastern time, we are done. So we have to get through a lot here in the next 20 minutes, and let's see what happens. Can you repeat, please, the three upstairs again?
Yep. So the up there's include energy, mood, and thinking and memory.
Okay, thank you. Next, we have, can baclofen and tizanidine be combined?
Yes. Baclofen works through a GABAergic neurotransmitter GABA, and Xanaflex tizanidine works through a different mechanism called the alpha adrenergic system. So it's two completely separate systems. And so, yes, you can combine them. And I oftentimes do at night. You can have an additive sedative effect. So I want you to be cautious about that. And I want to make sure that you talk to your neurologist before you try it. But yes, I will sometimes combine them together for a synergistic benefit.
Thank you. Have you ever heard of a PEMF mat? And if yes, then I'll ask the question. But if not, we're going to cancel this question.
I'm sorry, I have not. I apologize.
Okay, thank you. So for the person that wrote in about asking about PEMF mats, if you could explain what this is, then maybe we'll be able to ask the question. Meanwhile, though, there is another question similar, and that is the vibration plate. What can you tell us about that?
So a vibration plate is what it sounds like. It's like a platform that moves back and forth. And it can sometimes help with a couple different things. Where I have seen it used the most actually is in constipation. And I'll have a patient that will sit on it and it'll kind of vibrate, and it'll kind of help them get their gut motility moving. It can also sometimes help with some sensory things as well.
Great, thank you. Do sleep aids like Lunesta, Ambien help or harm your brain?
I am not a fan of sleep aids. I will at times prescribe them, but I do it very reluctantly. I don't think that there's necessarily any long-term damage to using them, particularly if you're using them for a short period of time. The problem that I have is a lot of people, whether they have MS or not, have very poor what's called sleep hygiene. So their behaviors surrounding sleep are not good, and they contribute to issues with falling asleep and staying asleep. And when you use a sleep aid, you're kind of like Bugs Bunny, like smacking you on the head and knocking you out. And that might help you initiate sleep. But as soon as you stop using the sleep aid, you have developed zero positive habits to help you learn how to sleep. And you can become dependent on these medicines. They also can contribute to cog fog, and they also can contribute to some fatigue, which are very, very common in the setting of MS. So there are situations where we have to use a sleep aid, but I try really hard to avoid them whenever possible.
Thank you for that. Now I'm going to ask a question that relates to that. What about all the doctors out there that recommend for people to use medical cannabis to help them relax or get a better night's sleep or et cetera? How can you respond to that now?
So medical cannabis doesn't slow down MS, but it can help with some symptoms. So medical cannabis does not help with bladder. It does not help with cognition. It does not help with depression. It does not help with balance. It can, in some patients, help with anxiety. It can, in some patients, help with spasticity or pain. And in some patients, it can help with insomnia. And I have a lot of patients that will find that they can use an edible form of cannabis or a tincture of cannabis before they go to bed, and they can have better sleep. I will make the same comments that I make with the sleep aids. I think that medical cannabis might be a little bit more natural, but don't fool yourself into thinking that there are no side effects, because there can be. And cannabis can impair energy levels in some cases, and cannabis can impair cognition in some cases. So there's no freebie. I do have many patients that have opted to use medical cannabis instead of Lunesta or instead of Ambien, or even instead of the spasticity medicines at night, so they get their sleep on.
Thank you. Somebody just shouted out that they also do Benadryl to help them get to sleep.
Yep. Again, I think that's probably the most common sleep aid in the United States, because it's over the counter and it's relatively inexpensive. And again, I think that you're better served long term if you can learn proper sleep hygiene and things to help you sleep. There are roles for things like Benadryl. When I give someone high-dose steroids, so today at the end of my clinic, I had a wonderful gentleman that I saw, and I needed to give him steroids for an MS attack, and it was late in the day. And so I asked him to take Benadryl tonight so that he can sleep, because my steroids are going to hype him up, and he's got to get a good night's sleep.
Okay, thank you. Next. Wow, the last time that you were on with us, somebody asked about CNMA as an apple U8 in a drug trial. And I don't know if you knew about it at that time. I think that somebody else brought it up, though, afterwards. Do you know anything about it since?
No. Shame on me. Now, I've read the paper, but I don't feel competent to talk about it right now. So I'm going to pass on that question so I don't provide misinformation. I think that would be inappropriate.
Right. Well, the person wrote that Dr. Gretchen Hawley mentioned it somewhere. I know I read about it as well, but I don't remember what it is. And so maybe for the next time we'll get up to speed. And I say next time, everybody, because Dr. Boster is on with us every other month. And hopefully that continues into 2026 as well. Okay. All right. Next, moving along here, we have what do you feel about myelin repair?
So I actually put out a YouTube video this morning, Monday morning. Yeah, so I guess that was yesterday morning. I'm losing track of time, on remyelination. Remyelination is outside of the discussion of symptomatic management. It gets into trying to slow the disease down and try to repair some of the damage. It's something which is actively being worked on, but we're not there yet. As I like to say, it's not prime time yet, but I do think that we're a lot closer than we've ever been. I think we're probably like 5 to 7 years out from having some remyelinating agents that are available to help treat MS.
Great, thank you. What can you tell us about fenebrutinib?
So there's been a lot of excitement surrounding BTK inhibitors. So BTK inhibitors stand for Bruton tyrosine kinase inhibitors. And these are small molecules, they're pills that have been around for a long time to treat certain types of cancers. And it turns out that they may have a role in treating multiple sclerosis. Now, fenebrutinib is a brand of investigational medicine, which is being tested right now by a company called Genentech or Roche. And at the Boster Center for MS, we're involved in fenebrutinib trials. We're studying this in relapsing forms of MS, and we'll probably get a readout probably the second quarter of 2026. There are several other BTK inhibitors which have been studied. There's a medicine called evobrutinib, which is made by a company called Serono, which did not work in relapsing MS, unfortunately. There's a medicine called tolebrutinib, made by a manufacturer called Sanofi. It did not work in relapsing MS. It did work in secondary progressive MS, which is very exciting. But we're still waiting on the data for fenebrutinib. Now, actually at the Boster Center for MS, I think that we're the highest enroller for fenebrutinib in the world. And we're very, very hopeful that it's going to work for treating our relapsing patients with MS, but the data's out yet, so we just don't know. We should get a readout on this the second quarter of 2026.
Thank you. Let's talk about tolebrutinib, since you did bring that up, and I wanted to let people know more about this anyway.
Yep.
This is, what was that, the Hercules trial that got it approved for secondary progressive MS without relapse. So can you please explain what secondary progressive MS without relapse actually is?
Absolutely. So when we studied tolebrutinib, we studied it in relapsing MS in a study called Gemini, which didn't work. We studied it in secondary progressive MS in a study called Hercules. And we're still studying it in a clinical trial called Perseus for PPMS. So let's focus on the Hercules trial. In the Hercules trial, we enrolled patients who have multiple sclerosis, and they've had relapses in the past. But they haven't had relapses on average for about 7 years, right? So they used to have relapses, but they haven't recently. And they have had progression of disability. They're getting worse independent from relapses. And so if you want to be very nerdy, we would call that non-relapsing secondary progressive MS, right? You're describing someone who used to have relapses, but they haven't recently, and they are getting worse. And those are the patients that we enrolled into Hercules. All the patients in Hercules took a pill. 2 out of 3 patients took tolebrutinib. They took the study drug that we're talking about. 1 out of 3 took placebo, right? So you had some that were taking the tolebrutinib and some that were on placebo, and the patient didn't know which one was which. They didn't know whether the pill they were taking was real. And I, the investigator, didn't know which one was real. That's called double blind, where we're not aware of the allocation. What we found at the end of the trial for Hercules was that if the patient was randomly assigned tolebrutinib, they got worse a lot slower. They got less worse than the patients that were on placebo. And the difference between the placebo-treated patients and the tolebrutinib patients was 29%. So it was almost a third reduction in disability progression over the period of the trial. That's very, very exciting because we haven't been able to do that before. And this has been identified as breakthrough status, and it is being fast-tracked at the American FDA, which is a very, very exciting thing to have happen.
Great, thank you for that. Any thoughts on UV light therapy?
So UV light therapy has become a hot topic, particularly on social media. And there's some very, very early fledgling discussion about how various light therapies may influence the immune response. I have yet to see compelling human data, which makes me think that it absolutely is the bee's knees. That stated, it's kind of interesting. I think it needs to be studied a bit more before we bring it into prime time. The theory is that by exposing the skin to different kinds of light, like let's say red light, you can promote anti-inflammation and healing and things like that. But I'm not completely convinced yet, and I need to see more studies before I can weigh in.
Great, thank you. Next, have you used IV treatment therapy for adding nutrients, vitamins, saline, etc.?
So I think what the person's talking about is kind of what we call hydration therapy. And so you can receive a medicine sometimes by your mouth, and you can receive a medicine sometimes by a shot, and you can receive medicine sometimes by a vein. There are certain medicines which you can't take by mouth. So, for example, there are certain medicines that are proteins, like antibodies, like, say, natalizumab, Tysabri, or ocrelizumab, Ocrevus. These medicines are proteins, and if you swallowed them, you would digest them in your belly. They would dissolve in the same way that if you eat steak, it goes in your belly and it dissolves. And so that's why those medicines have to be given what we call parenterally, where they're given through the vein, or other ones are given as a shot. What this person I think is asking about is something slightly different, which is like a hydration therapy. And it's become kind of popular, particularly down on college campuses, where you can go to a hydration station and you go in and you pay some money and they set up an IV and they'll run in fluids and rehydrate you. And they'll give you some vitamins and minerals and things like that. I think where I see it done the most is when someone's had a big night out with the boys and they're a little bit hungover and they're trying to get their self put back together. Do I think it has a role in MS care? Not so much. Do I think it's important to drink water? Yeah, I do.
Okay, thank you. Next, going back to that PEMF, it is pulse electromagnetic field.
Yeah, okay.
It's a pulse electromagnetic field, Matt. So now that I said that, do you know anything about it and how that might help a person?
So I've had a couple patients that have gotten a hold of them. I've had one or two patients who thought it might help them, but I actually don't have any knowledge in the top of my head about data supporting their use.
Okay.
When there's therapies like this, which are not taught to me in med school. So I'm an allopathic doctor, I'm an MD. And if something wasn't taught to me in med school, that doesn't mean it doesn't work. It just means I wasn't taught about it. And I generally have 3 rules, in quotes, when I'm trying to counsel a family about trying something outside of what I know about, right? Number 1 is that it can't be dangerous. And those mats are not dangerous. You're not going to electrocute yourself or something silly like that. If you would, then that would be bad. Number 2, it can't be instead of something that we know works. So if you said, hey, Dr. B, I'm going to stop my Gilenya disease-modifying therapy pill, and instead I'm going to use this mat, I would be worried about that. Number 3, it can't be too expensive. And only you know for your family whether something is too expensive. And so those are the 3 rules that I apply when I'm trying to guide someone in thinking about something like a mat like that.
All right, next one is what can you tell us, or what can a person do that has feet numbness on a daily basis?
There's a couple things that we want to do. Number 1, if your feet are numb, I need you to literally look at your feet every single day. Once a day, say at the end of the day, you need to take your shoes off, you need to take your socks off, you need to pull your foot up, and you need to inspect your foot. You want to look in between your toes, you want to look on the bottom of your foot, you want to look on your heel, you want to look on the top of your foot. That's very, very important. The reason is that if you don't have normal sensation in your feet, you can bang your foot, cut your foot can get infected, you can have problems with your feet that you're not aware of. And that's unfortunately a great place for infections to take hold. You can get ulcers on your feet, and this can be very, very serious medically. And so just like with a diabetic that has peripheral neuropathy, someone with MS who has numb feet, you need to visualize your feet every day. Number 2, knowing that you can't feel your feet. Sometimes you're not sure where your feet are in space. That's a type of sensation called proprioception or position sense, and that can be impaired. And when your position sense is impaired, it can increase the risk that you misstep and that you fall. A way of combating that is to turn the lights on when you're walking. So if you have to go to the bathroom in the middle of the night, you got to turn a light on so that you can see the floor, because visually it can help you figure out where to put your feet. And you want to make sure that the path is clear. So don't leave your shoes and your briefcase and all the things laying on the floor, because you're creating trip hazards for yourself. Those are two things that you can do that are really important.
Thank you for that. Next one was age related. Let's talk about this because this is a very hot subject, and I think that this is going to be our last one because it's almost 8:15. There are those that want to know if there's anything available in research studies for people over 65. There are those that just want to know if they need to stop their medication after 65, and there are those that want to know if they're first diagnosed at 65, what can be done for them.
So this is a very hot topic. It's a very debated topic amongst MS nerds like myself. And there's a couple different camps. I'm in the camp of keep on keeping on. I am a big believer that as long as you have a nervous system with features that you like seeing or smelling or moving, I want to preserve that neurologic reserve. And as long as you have an immune system which risks attacking it, then I want to do something to prevent that immune system from occurring. People who are 65 are statistically less likely to have attacks compared to 35-year-olds. They're statistically more likely to have progression of disability. And I remind people that these MS medicines, particularly the newer ones, do more than just prevent attacks. They also slow disability progression and brain volume loss. So I like that. I want that for you. I do not feel that it's appropriate just because you happen to have celebrated your 65th birthday that you stop your medicine. I would much prefer to use a style of treatment called de-escalation, where we might decrease the potency of your medicine to something with a more favorable side effect profile, but I wouldn't stop completely. Now, this is also a challenging topic to study. It has not been studied a lot. There's reasons for that, but it is increasingly being studied more and more, and there are some papers on it. Again, I fall into a camp of keep on keeping on.
Okay, great. Thank you so much for that. And Dr. Boster, you ended right at 8:15 p.m. I do want to say thank you very much for joining us every other month, and for all the work that you do for the MS community on your own shows, on our shows, on other people's programs. I shouldn't say shows, but programs, all right? All these are education programs. Some people call them shows. So, you do a tremendous amount for the multiple sclerosis community. It takes up a tremendous amount of your time and energy. And I, for one, say thank you. And I'm sure there are thousands of others. So let's all have a great night, and we'll see you again soon. Okay? Thank you.
Well, Stuart, I also want to say thank you to MS Views and News for the opportunity. And I would love to take you up on the offer to do this every other month all next year.
Awesome. It's done deal.
Take care, guys. Have a great night, and thank you again.
Good night. Bye-bye.